Right, so presentation lecture 5, back pain. So a really, really common presentation that you'll see throughout medicine. As neurologists, we are referred back pain a lot, asking if it can be a non-structural problem, and in the main it isn't. It's a really common reason to seek medical care, both in GP and secondary care, and £150 billion is spent worldwide on the medical management of back pain, and that doesn't include the money that is lost from, domestic inability, being off work. So it's an extremely expensive condition, both in terms of psychological well-being and output. 90% of it, so the vast majority, is mechanical due to, sort of musculoskeletal problems, some of which may just be muscular in nature and self-resolving, though it can cause quite a lot of disability in terms of pain. But you can also have disc protrusions and other neurosurgical emergencies associated with back pain. And there are other features that you would look for to try and differentiate between simple musculoskeletal back pain and a more sinister cause that needs prompt imaging and treatment, and we call those red flags. So when you are taking a history of somebody with back pain, it's important to understand if there were any provoking factors. So if somebody has been to the gym for the first time and they didn't really know what they were doing, and then they tried to copy some practice weightlifter doing a deadlift and instantly their back went, it's quite clear what's going on there. And if the pain is very severe, if they have radiating pain down one leg, if they have weakness, you need to scan that person looking for disc protrusion. Other provoking episodes may be sort of a fall, so you might think about a vertebral fracture. It's important to ask about these things. Things like work as well, if people are sitting for long periods, that can predispose to muscular back pain. And if something is mainly muscular, you wouldn't expect things like weakness or numbness. You would ask about significant comorbidities and medications. So comorbidities that are very relevant in back pain are a diagnosis of cancer. So if somebody has a known cancer and is having treatment for that or is being managed conservatively, there is always a concern, particularly in certain cancers like prostate, and breast and lung, for example. They have a tendency to metastasize, particularly to bone. And we worry about what we call malignant cord compression or malignant spread to the bones of the back, where you get lesions which metastasize or spread to the vertebrae, and then they can encroach and compress the spinal cord. And that is both an oncological, cancer-related, and neurosurgical emergency. And people who are treated promptly, even if they have a limited life expectancy, can have significant improvements in quality of life. Medications that are very relevant are immunosuppressant therapies. So if people have a cause for being immunosuppressed, like certain medications, chemotherapy is another one. If they are poorly controlled diabetic, they have a greater tendency to have unusual infections. And one infection that can be difficult to detect, but particularly if people are delirious and confused, which they can be with infection, is discitis, or infection of the intervertebral discs. And we'll touch on that. Onset and location, if it's sudden and provoked by an unusual activity or twisting, then you would think about mechanical disc protrusion or just muscular wear and tear of the back. You'd expect sort of musculoskeletal structural problems to be more in the neck, particularly in sort of, all of us tend to be hunched more with phones and with keyboard work. Lower back is very, very common. About 84% of us as human beings will have some lower back pain at some point in our lives. But thoracic back pain, that tends to be, but not invariably, but it tends to be due more to distinct pathology. So metastases tend to go to the thoracic spine. Discitis can be anywhere, but it tends to be more in the thoracic spine. And certain arthritides or inflammatory arthropathies can cause problems with the thoracic spine, particularly as well. Referred pain can give you a clue as to the cause. So if somebody has referred pain into their arm, from their neck or down their leg in a sort of sciatic distribution, so down the bum and down the back of the leg, particularly when they move in a particular way, that suggests that they have wear and tear and that they also have radiculopathy. So that would be sort of compression of the nerve root as the nerve leaves the vertebrae. Other features which are worrying, which would trigger you to scan somebody promptly, are nighttime pain, so pain that wakes you up, particularly in the thoracic region. It doesn't let you go to sleep. Fever, you would think about both infection and metastasis. Pain worsening on movement. So the majority of people with muscular problems and even inflammatory arthropathies, they might struggle to get moving, but once they are moving and upright, things tend to get a bit better. People who can't move at all and are very tender to touch over the bones, that tends to be more of a sinister cause, like discitis or a metastasis. And warm-up phenomena tends to be a feature of rheumatological problems. So if you have an inflammatory arthropathy, inflammatory arthritis, people are very stiff for the first half hour or hour of the day, and then they improve as they move around. So with examination, you're looking for features of an upper motor neuron lesion. So is anybody, do they have spasticity, increased tone? Do they have brisk reflexes? Are they weak? Are they numb? That usually cannot be put down to just muscular pain. You can do a straight leg raise. So that's where you lie someone on the bed and you raise their leg. And if they sort of catch at about 30 to 40 degrees, then that suggests that the sciatic nerve is being impinged, and that's typical of sort of structural lower back pain. Bilateral positive straight leg raise and sphincter problems or problems with bladder and bowel suggests that there might be imminent compression either of the cauda equina or the lumbosacral spine, and they should have prompt imaging. You palpate the vertebral body, so you can either use the flats of your fingers, or in the past people used to sort of gently knuckle the back of the spine. If there's exquisite tenderness, particularly over the thoracic vertebrae, you worry about discitis, you worry about a metastasis. And then you look for systemic features. Does somebody have fever? Are there skin changes, particularly over the back? Is there contusion, which suggests injury? These are things that give you clues. Myelopathy, fancy word for cord compression and degenerative spinal issues. So myelopathy is just disruption of the spinal cord, which can be structural or can be due to other features like inflammation. Other cord lesions which can be painful but cause sensory motor deficit. Tumours, particularly within the spinal cord, very rare, but it happens. And inflammation like MS, transverse myelitis. Radiculopathy or compression of the nerve root can cause referred or radiating pain, typically from the neck into the arm or in the leg, or from the lower back into the leg, so sciatica if it's L5S1. Cauda equina or conus medullaris syndromes, so they are technically lower motor neuron problems, and it's the collection of the nerve roots being compressed by lumbosacral disc herniation or other structural problems, and like tumour or things like that. And it is an emergency, so you're looking for leg weakness, leg numbness, particularly both legs. And if they have sphincter problems, even if early sphincter problems, so urgency, and they just have a little bit of insensitivity when they wipe, for example, that is an emergency. And you can salvage somebody's leg function and continence if you scan them quickly. And if you find, impending cauda equina and get them to surgery quickly, that can keep them mobile and keep them continent. So here are some examples of disc herniation. So the first image shows a cervical lesion, so in the neck. So that's a C5, C6 disc herniation for somebody with severe neck pain and weakness, modest weakness of both arms and legs. And this person had neurosurgery and had good restoration of their power, if not complete. And the other image is L4-5 disc herniation for somebody with chronic lower back pain who suddenly developed weakness of the legs, and they again had decompressive surgery and some good restoration of function, though they still had lower back pain. Cauda equina syndrome, so cauda equina means horse's tail. That's the compression of all the lumbosacral nerve roots by a disc in L5S1, and you can see the black disc sort of pushing those nerve roots and compressing them. And this person had profound leg weakness, incontinence, fecal incontinence and urinary retention. They were operated on, but I think they did not have a good recovery because it was quite a complete presentation by the time they got to surgery. Discitis, so that's infection of the intervertebral disc. You can see in the CT image that there's erosion of the vertebral processes, the bones at the back, by infection, and you can see on the MRI how the infection is kind of eroding and causing collections of pus, which are then compressing the spinal cord. And this person was a poorly treated diabetic who was also immunocompromised through medication. And this is the MRI scan of a lady with breast cancer, which was malignant, who presented with bilateral leg weakness and numbness up to the umbilicus. But her cord compression is actually quite high, around C5, C6. And again, somebody coming in with these focal symptoms, bladder and bowel problems, leg and arm weakness, and back pain in somebody with a history of breast cancer, that is an emergency and should be imaged very rapidly in discussion with both oncology and neurosurgery done quickly. And they may have decompressive surgery or they may have radiotherapy to try and preserve function. So, summary of back pain. So, history and examination, like always, is key, but we look for red flags. Is there cancer in the background? Is there fever? Are they immunocompromised for any reason? Do they have poorly controlled diabetes? Is there a provoking activity? Did this just start when they were in the gym or they twisted? Examination should look for any focal neurology, including bladder and bowel function. You do need to do a PR examination and a bladder scan for these people, particularly if there's bilateral leg weakness and numbness, saddle anaesthesia, and a rapid discussion with neurosurgery to try and preserve function. Imaging and specialist input are really important. Don't struggle with these patients alone. Always ask for senior help. Thank you very much.